We thank GRAIL for their support of the 2022 annual CGA meeting.
Hello, everyone, and welcome to our podcast. My name is Greg Idos, and I'm a gastroenterologist and cancer geneticist at the City of Hope National Medical Center and also a member of the CGA Council. Today, we have the pleasure of speaking with Drs. Jordan Karlitz and Whitney Jones about multi-center early detection tests and about their work on the GRAIL Galleri test, which I'm sure many in our audience have heard about and are interested in learning more about. Dr. Karlitz is a gastroenterologist and former GI chief at Denver Health Hospital at the University of Colorado. And many in the audience may be familiar with his work from Louisiana and Tulane, working on the problem of colorectal cancer in the underrepresented communities there. He is now Senior Medical Director at GRAIL and Chair of the GRAIL Scientific Review Committee. And he's interested in studying how multi-cancer early detection tests can be implemented in high-risk population, including Lynch syndrome and others, which is appropriately apt for our audience. In addition, he's joined by Dr. Whitney Jones. He's an advanced endoscopist and gastroenterologist, professor from Kentucky, who had focused his public health work on CRC screening rates in underserved populations. He's also Senior Medical Director at GRAIL and is working with high-risk populations. So thank you both for joining us.
Great to be here, Greg.
Yeah, great to be here, Greg. Thank you for the introduction.
So Dr. Jones, Dr. Karlitz, it's great to have you both. What is a multi-cancer early detection test and how does it work?
So multi-cancer early detection testing, for example, Galleri, which is our commercially available product at GRAIL, really represents a paradigm shift from single cancer screenings. So what happens is there's a blood draw, and we have technology that works by analyzing methylation patterns on circulating cell-free DNA in the blood. And if a certain threshold is met, the test returns a positive cancer signal. And through AI and machine learning, we could actually analyze the pattern of methylation. And this allows us to predict the most likely organ or tissue of cancer origin with about 90% of accuracy. And then this ability to target with accuracy the organ or tissue of cancer origin really allows us to proceed with a tailored diagnostic workup. So if you have an upper GI tract signal, for example, we could target the workup there as opposed to doing like a PET CT or something like that on all patients. So it really allows a tailored diagnostic workup. And another thing for this audience is, though, even though this is a DNA test, it's really important to stress that this is not a germline panel test to look for hereditary syndromes like Lynch or BRCA. It's really a test looking to detect cancer in the body in real time. And I'll just go on and say a few more things. Importantly, 70% of cancer deaths are due to cancers with no USPSTF screening guidelines. And really a key goal of Galleri testing is to provide a mechanism to target early detection in these patients where there's really not great screening available, and we want to detect cancers early before they spread. In terms of cancers covered by the USPSTF, so we know these, right? So it'd be colorectal cancer, breast, lung, cervical, and at times prostate. Galleri testing is not meant to replace these screening tests, so that's really a key point, but it can complement them. So we do recommend that patients undergo these USPSTF screening tests as recommended by their providers. MCED testing can be used in addition to these USPSTF guideline screening tests and really provide a safety net or backstop for patients that may not be up to date on their USPSTF screenings.
You know, you spoke about the platform focusing on methylation patterns. Why does it focus on methylation patterns as opposed to other markers that can be measured?
In our first original sub-study, we really had no idea what the best way to evaluate cell-free DNA was in blood. We were an outcropping of non-invasive prenatal testing that Illumina was doing back in 2015. And about 10 women out of 125,000 specimens had extremely abnormal cell-free DNA patterns. And those women all went on to be diagnosed with cancer, although their children were delivered normally. So that was really the aha moment, sort of a serendipity moment that you could detect cancer signals in blood. And so GRAIL was spun off from Illumina in 2016. And the original part was to figure out how do you assess for cancer signals in the blood, because it was really unknown at that time. And the first CCGA-1 study, which is the circulating cell-free genome axis, I'd recommend everyone read that because it's a great insight into how this worked, utilized samples from about 2,800 folks to evaluate prototypes for next generation sequencing because we had no idea. And we looked at targeted enrichment assays to look for somatic mutations, whole genome sequencing to look at copy number variations, as well as a very new issue at that time, which was whole genome bisulfite sequencing to evaluate for methylation, also known as the epigenomic signature. And methylation outperformed whole genome sequencing and targeted mutation panels in cancer detection in our ability to detect and as well as predict a cancer signal, George. So it was not only better at detecting, it also hacked that embryological methylation pathway that really differentiates your liver cells from other cells. The other thing about methylation, it doesn't require you to do concurrent white blood cell sequencing as in mutations. So we don't have to deal with areas around CHIPs and clonal hematopoiesis at all. And again, I think the really key thing is that cancer test based on blood that just tells you the cancer somewhere versus one that allows you to target that workup and evaluation is going to be really impactful on screening efficiency and I think as well as the patient experience.
Now, the test that we're talking about focuses on this methylation is the GRAIL Galleri test. Is that right?
Yes.
And what are the kinds of cancers that the GRAIL Galleri test can detect, and how good is it at detecting cancer?
Well, that's a great question. First of all, it's important to know that we detect a common biological shared cancer signal first. And this is based upon methylation patterns, both hyper and hypomethylation patterns that have been derived to be clinically important to identifying those cancer signals. And they're really spread out through the genome. In terms of identifying cancers, because it's a more pixelated view, in other words, you have 30 million methylation sites in your DNA, about 1 million of which are important to the cancer journey. We have the capacity to identify many cancers. In fact, we think we will identify cancers we haven't even trained on yet because of that common shared cancer signal. And so we know we've identified over 50 different types of cancers already. And again, they vary with regards to their sensitivity, which is primarily derived from that tumor's biological behavior in terms of shedding cell-free DNA into the blood. So tumors with low turnover rates, for instance, take prostate thyroid, they're going to have really minimal cell-free DNA, and we won't be able to detect those. One of the other big issues is not only tumor aggressiveness, but also the importance of stage. Obviously, smaller stage tumors, earlier stages, have less biological capacity and less tumor to shed. So we do see improving sensitivity as stage advances, but the capacity to identify a significant percentage of these in stage 1s and stage 2s is really amazing. And so this really spans the spectrum. I'll tell you more importantly, the ones we don't find maybe. Brain cancers because of the blood-brain barrier. We don't pick up a lot of skin cancers because of the lack of dermal engagement. It doesn't get into the bloodstream. And then very slow-growing tumors such as I said, prostate and thyroid. But we do pick up hematologic cancers as well as solid organs and luminal organs.
So as Whitney was saying, the sensitivity can vary depending on how aggressive the tumor is. In terms of aggressive cancers that could grow quickly, I can give an example of sensitivity by stage. So pancreatic cancer, for example, as we know, could grow quickly but not present with symptoms until late stage. So this could be really a challenging cancer to diagnose. So when you look at stage stratification based on our CCGA data, which was that case control study, we were actually able to detect between 60 to 62% of stage 1 and 2 cancers. And that rose to 85.7% for stage 3. And then obviously at stage 4 is higher at 95.9%. But detecting almost 2/3 of early stage pancreatic cancers, we think is really quite something and a clinical win. Because as we know, there are certain patients that are eligible for pancreatic cancer screening. So for example, if they have certain hereditary syndromes like Lynch, BRCA, et cetera, or if there's a family history of pancreatic cancer, but many, many patients with pancreatic cancer are not really going to be eligible for screening. So we feel that this could really provide an ability to detect these patients at an earlier stage. And then just kind of going on to the specificity of the test. So that frequently comes up when you're talking about screening large populations. So that's really the false positive rate. So the test was really carefully designed to have a very high specificity. In fact, it's about 99.5%. So the false positive rate would be half of 1%. And just to kind of give an example, so if you're going to test 200 people, Galleri, you're really only going to generate one false positive. And that was really by design, because if you're going to be testing large portions of the population, We do not want to be generating false positives for a number of reasons. Obviously, we don't want to make patients and providers anxious. And in addition, we don't want to be creating pathways where large amounts of diagnostic testing is being performed that doesn't subsequently lead to a diagnosis because it's a false positive. I do want to talk a little bit about the positive predictive value. So that's actually the chance that a patient with a positive test result has cancer diagnosed on that subsequent workup. And the PPV for our test is actually around 43 to 44%. And to place that in context, that is about an order of magnitude higher than most single cancer screening tests. So that really means that if you have a positive result, there's a good chance that a patient could have cancer. And it's really important that both the person ordering the test and somebody that's going to be receiving that patient to perform a diagnostic workup. So for example, like a GI doctor that might have to do an upper endoscopy, it's really important that they be aware that that PPV is high because we want them to understand the metrics of the test and get that patient in for an expedited workup.
Thank you for those test performance characteristics. I know that many in our audience will probably be wondering about that. In thinking about who we should be ordering these tests for, what are the types of patients we should be looking out for ordering this test, and how frequently do you think we should be ordering this test?
That's a great question. Currently, the test is being studied in individuals with an elevated risk of cancer, and the easiest way to identify that elevated risk is by age. That's far and away the most significant driver of cancer. So our focus has been on people who are 50 years and older to use that test. And we really see this more likely as an annual type of cadence simply because of the most aggressive cancers have some of the shortest dwell times. And it also gives us a chance, just like pap smears initially only picked up about 50% of cervical cancers when they first came around, but that serial and aggregate sensitivity to testing year after year after year gives us a chance to identify cancers over time before it spreads, because many cancers have a more slow and progressive nature, like colorectal. And so even if we're not picking that up in its first round, we have that opportunity. So we want to take advantage of that cumulative sensitivity over time. And it continues to evaluate it when the intervals are best in our clinical trials. Right now, we're thinking 1 year, but that's being evaluated, including at the NHS Galleri trial, which is a large study going on in England, where there's going to be 3-year follow-ups. There also may be some people who have equivalent risk who are under the age of 50. And again, at the CGA, we all know about our patients with elevated risks, such as germline mutations. But other considerations would be people who are cancer survivors, heavy smokers, people who have immunosuppressed states, such as transplants or primary or secondary immunodeficiency disorders, and people with environmental exposures, potentially firefighters, people who have other additional risks. I think of veterans and the fire pits that we've seen over in the Middle East. And so we're really evaluating that right now as we continue to pursue clinical trials to answer those questions to best dial in those risk groups.
You talked about some of the clinical trials that are going on with the GRAIL Galleri test. And I think many in our audience are looking to the evidence of how well the Galleri test performs. Can you and Jordan talk about what are the ongoing studies that are happening with the test and where we can try and find this data?
Yeah, I'm happy to kind of jump in on that. I know that Whitney already mentioned the NHS Galleri study, which is actually a very large study in the UK that has completed enrollment with 140,000 patients. So that's really a 2-arm study looking at an intervention group with MCED testing on top of standard of care versus another arm with standard of care alone. So that's a very large study that completed enrollment actually quite quickly, given that there are 140,000 patients. But in total, with regards to the number of patients that have been enrolled in GRAIL trials, it's been approximately 335,000 patients. So again, 140,000 in that NHS Galleri trial in the UK, but we've had other trials as well. So Whitney already mentioned the CCGA trial. That was a case control study of around 15,000 patients. And really that, because it was a case control study and we knew who had cancer and who didn't, and we were able to do testing on everybody, that allowed us to calculate metrics like sensitivity, specificity, positive predictive value, and negative predictive value. So that was obviously an important study. Most recently, we had the Pathfinder study that was presented at the European Society of Medical Oncology this past fall. So that was actually a prospective study of around 6,600 patients that were followed over the course of a year. And so every patient had MCED testing when we followed those patients over time. We didn't know who had cancer at the beginning, in contrast to that case control study with that CCGA study. And really in the Pathfinder study, that was really an important study because we were able to really see how the test works out in the wild. And we were able to see that a substantial number of cancers were able to be detected on top of what would be detected during regular screening. And there is another study that's important to mention called Pathfinder 2, and that's currently ongoing. And it's similar in design to the original Pathfinder trial, again, a single-arm study adding MCED to standard of care. But the Pathfinder 2 is really enriched for a more diverse and underserved patient population. As we know, it's really important to understand how the test is working and access in that population.
That's great. And I think our audience would be looking forward to those results from Pathfinder 2 and NHS Galleri. I think those are going to be some really important studies that are going to reveal some really important results about this field and about how we take care of our patients. I think one of the major questions that our providers and patients will have specifically about this test is, what does it cost them? How much does the test of the cost, and is it FDA approved?
Well, like any new test and any new biology, I always harken back to how much it used to be to get BRCA screening a decade ago. So the cost currently is $949, and it's available commercially, but it needs to be with a prescription from a physician or a provider. We have several select insurance companies that are following it in Medicare Advantage, and we're talking with some folks in Medicare. But our goal, of course, is to get this in widespread insurance coverage, including Medicare and Medicaid. Jordan and I both spent a lot of our career working on underserved populations, and the real benefit of this test should be expanded to everyone, particularly those who probably have significant increased risk because of their socioeconomic status. But we are a lab-developed test and CAP and CLIA certified, as well as New York State certified.
I think that's great. And I think it's important to be able to provide these types of tests to all populations. And you both spoke about and had done work on in underrepresented communities and tried to address health disparities in your work. And you had just alluded to that. I'm wondering if you can speak more about the justice, diversity, equity, and inclusion efforts that you guys are doing at GRAIL. And is there a concern that these multi-cancer early detection tests, because they're kind of new genomic technology, that they could exacerbate disparities?
Yeah, no, that's a great question, Greg. So DEI, diversity, equity, inclusion is a key focus of GRAIL and Galleri testing. And as we know, those at highest risk of cancer may frequently be the ones that are currently unable to afford testing or potentially not have access to testing. We have people living in rural areas that maybe have a hard time accessing specialized services. So as Whitney had mentioned, Whitney worked in Kentucky, and before I was in Colorado, I was in Louisiana. I was actually chair of our colorectal cancer roundtable. I know Whitney was highly involved in the colorectal cancer roundtable in Kentucky as well. And one of the things that we were doing with colorectal cancer roundtable is trying to, get people in for colorectal cancer screening and overcome barriers to care. And you could kind of really extrapolate those experiences that we had with that to MCED testing. Hopefully our experiences overcoming some of those barriers in our respective states can really, kind of help us going forward. So clearly one of the goals is to get the cost of the test down, and obviously obtaining widespread insurance coverage will be really, really important to minimize any type of disparities in access to testing. Another key issue is if you have a positive MCED test, obviously you want to create pathways where you could get to your diagnostic testing quickly and efficiently. So that's another issue that's really important. And again, there's similarities to the colorectal cancer screening space where Whitney and I learned from those experiences. As I mentioned, many of our studies, for example, Pathfinder 2, are really enriched to assess MCED testing in diverse patient populations and to better understand testing in underserved patient populations. And clearly the ultimate goal is to narrow cancer screening disparities through widespread coverage and access. Again, this is a major focus of the company, and Whitney and I have personal experience with this. And I don't know if Whitney, if you want to kind of chime in on your experiences in Kentucky and how those might play into what we're doing here at GRAIL.
Well, I would just say this, after being with the company for 2 years and in the space, it is in our DNA to try to make sure this test gets out to the people who will benefit the most from it. And I think that's supported by the fact that this legislative effort to get coverage is supported by more than 400 organizations who are supporting the MCED Coverage Determination Act, which is actually resubmitted just yesterday. So I don't think this test as vision becomes fulfilled until it's available in FQHCs and community health centers, and even for those who may lack insurance, because the cost of cancer affects the entire country. And this is an incredible time to really add a new leg to the table of cancer control. We've been working on single cancer screenings. We've been working on smoking cessation. We've been working on treatment. We've had a lot of incredible improvements, but being able to identify cancers at their earlier stages in people who are asymptomatic is an incredible leap forward for us. And it's really that combination between improvements in genomic sciences and sequencing, as well as artificial intelligence, that allows us to get to this moment at this time. So we are really hopeful that as we look forward, and here we are in CGA-IGC thinking about GI cancers, but what I can tell you is whatever cancer you're focused on in your specialty, the greater benefit to your patients will be that multi-cancer effect, looking for all cancers simultaneously, in addition to the one that you may specialize in or focus on.
We at the CGA would like to thank you both for all the work that you've done and are going to do in trying to make sure that this test gets out to everybody. It doesn't exacerbate disparities and actually bridges the gap in getting more people screened. And just thank you for both your time and sharing your expertise with this developing field of multi-cancer early detection tests. I think this is going to be of major value to our members and listeners as this field grows. And hopefully we can talk again and see how things are going in terms of those NHS Galleri studies as well as the Pathfinder 2.
Thank you so much, Greg, for inviting us. Greatly appreciated, and we're looking forward to working with you.
Really appreciate the time and exciting to be in this era of medicine.